introduce our speaker. Sorry, the recording just started. Welcome, everyone. It's my pleasure to introduce our speaker, Qian Zhang. She's the Tencent Professor of Engineering and the Chair Professor of the Department of Computer Science and Engineering at Hong Kong University of Science and Technology. Inside Hong Kong University of Science and Technology, she's also director of various initiatives, including the Division of Integrative System and Design. She's co-director of the Huawei Innovation Lab, as well as the director of the Microsoft Research Asia Information Technology Key Laboratory. So Qian, please put your slides in full screen, and the floor is yours. If you have questions, you can, audience, put them in the chat and we'll ask them at the end. Thank you very much. I think you're muted. I think we need to unmute you.
Thank you. It's a very strange configuration. I need to wait to the host to unmute me.
Yes, yes. Sometimes we forget that.
Thank you. Thank you for the kind introduction, and thank you for inviting me here today. So I want to spend some time share with you the recent efforts that we are doing, push the limit of mobile sensing, smart healthcare in the age of AIoT. So yeah, I think all the audience here has the same context that we're all facing the fast growth of IoT device, and then the global number of connected IoT devices expected to grow for the many years to come. That's why we have a lot of interesting work to do. I think fundamentally, there are a lot of smart scenarios that's being enabled. People talking a lot about smart things, smart home, smart healthcare, smart transportation, even large-scale smart city. To enable those smart things, AIoT actually play quite essential role. And particularly for our mobile society, we are working on how can we efficiently sense and understand, how can we effectively transmit the data, and how we can have a nice way to really get the idea what those data really means for the particular domain or for the particular application. So today, I want to particularly focus on the sensing part. And we believe actually sensing, especially the technology with the technology pushing, the sensing actually got chance to push to the limit of ubiquitous intelligence. So for our particular group, we are working on sensing around the human. So that's why if we're looking at the different type of sensing technique, we can see that we have the wearable sensors, different type of wearable sensor design, RMU, SCMG, etc. And then we can also have, we call it as a contact, but not wearable sensing modality. For example, optical is a perfect example. We can have the optical sensor we put under your pillow, under your mattress, so as very, very tiny vibration will be able to get that information. So user no need to wear anything, but it's still kind of like contact-based sensing. And more interestingly, there are a lot of contactless sensing, and camera is a perfect example. This is a typical vision-based sensor. And due to its potential privacy issue that may cause, so recent years, researchers have strong interest in looking at the other potential contactless sensor, like acoustic sensor, RF sensor, light-based sensor. I pretty much call them as a communication media serving as a sensing purpose, because those medias traditionally we are playing with them for communication purpose. Now we realize actually there are a lot of fun stuff we can come out of them by exploring its sensing capability. So in our group, we're particularly interested in looking at the application domain, which is smart healthcare. And after like more than 10 years working on this area, particularly work together with the doctors in various hospitals, we find out that AIoT actually could be a very, very essential tool to empower the life cycle-based health management. And we particularly interest in the home-based setup. You don't need to wait until you have become a very severe stage, go to the hospital. After you really got the diagnosis, so after you come back, you still need to do a lot of good like rehab or health management. How can we do that? So AIoT can empower in the way that there are a lot of information we can get when you're back home, particularly when we can capture your vital sign related information. For example, we are talking about blood pressure, heart rate, breath condition, etc. And there are also some other like lifestyle behavior, but they are health related life cycle behavior. For example, our walking gait, our eye blinking pattern, the way that we talk, and definitely your sleep quality. So all those are for sure is a life cycle, is a health lifestyle based behavior. If we have a good understanding about the behavior, and meanwhile we have a good understanding about the vital sign, we could leverage in the learning scheme and learning technique that we further explored to discover some new biomarker or digital biomarker for the disease. And we also could be able to assess the progression for the chronic disease. Not only that, we'll also be able, basing on our understanding for personalized situation and give you some personalized intervention. For example, give you the recommendation about the rehab exercise that you should take, give the recommendation about the breath exercise you should take, etc. And then eventually you should ask, how effective is that recommendation or intervention that you take? Don't worry, we are using the AIoT, so that's why it's a very natural closed loop. You can do sense again about, or in a continuous manner about the behavior, about the vital sign indicator. So all this become a very natural like life cycle management framework to support various type of chronic disease and various type of health management needs. So that actually triggers our work in HKUST. We are pretty much aligned this direction to do a lot of investigation. So particularly in our group, application-wise, our focus is healthcare, as I just mentioned. So we particularly check about the vital sign, about the behavior, so that we'll be able to discover biomarker for a certain disease. We'll be able to access the progression. We even be able to provide some digital therapy suggestion. But what is the technology behind to support us? We are working on pretty much two sides. On one side, we need to play with different type of sensing modality. As I just mentioned, human focus, human centric, different ways to sense it. So that's why in my group, we are playing with all this type of sensing modalities, starting from wearables to optical sensor, and also to RF, acoustic, light, those contactless sensing modality. And the sensing modality, one or multiple of them, will be equipped in your edge device. So another part of the work that we need to do is basing on the sensing data that we can obtain or we can get from the sensing modality, then design the proper learning scheme so as we can have a better understanding in terms of disease assessment, in terms of evaluate how effective it is when we are giving you certain like therapy suggestion. And the particular challenge or the particular uniqueness in terms of the learning design that we need to pay attention to is that the edge device itself is resource constrained. So that's why we need to design more and thinking more aligned the resource constrained manner. Moreover, when we are playing with human, when we are sense humans' behavior, a lot of chance we get the training data for that particular subject, but then we want to apply our idea to the new user that you never think. So that's why the generalization is definitely something we need to consider. So pretty much all the work that I will introduce later on, we all following such a big picture in terms of the context setup and in terms of the methodology that we are playing with. So with this, our group will actually focus quite some chronic diseases. And then it's very fortunate that through the past 10 years experience, we got a lot of chance work together with some senior doctors in different hospitals, and we built a very good connection with them. Through the conversation and collaboration with them, we really figure out some diseases that really worth pay attention to, especially under home setup. So that's why in my team now, we are pretty much focused on 5 sub-directions. We are working on breath-related issue. We are working on home rehab-related issue. We are working on the way that we can do contactless home management and monitoring. And we are also working on food. We are particularly interested in food nutrition, food safety, which we believe is also part of the healthcare's umbrella. And also we are working on the optical sensor. So that's why we put that as a back sensor format so we can do nighttime monitoring, not only in the daytime behaviors. So today I want to actually select several pieces of work as an example. I'll not be able to cover all, but I will choose some typical ones for the kind of information exchange. I think later on, if we have interest, we can have more exchange and then maybe even have some collaboration, as we just mentioned. So let me first use the breath-related things as an example. So for this particular part, we're particularly looking at different type of respiratory disease. And we're particularly interested in COPD because that's a common lung disease and it's causing because of the restricted airflow and then breathing problem. So it's very sad that this is a degenerative disease. So that's why we cannot just cure the entire COPD. But if we do it, manage it properly enough, we could provide better quality of life for the COPD patient. So that's why a very natural question we ask is, how can we access the lung function of the patient in time? Hopefully frequently enough so as can be in time to capture the degradation. And moreover, can we provide more like a breath-related exercise as the rehabilitation tools so as to help to further strengthen their breathing, improve their breathing condition. So with this, keep in mind, I want to introduce 2 pieces of work. The first one is what we call ear spiral. So the whole idea is we want to do non-function assessment. When we want to do non-function assessment, if you check with the doctor, he will say, go to the hospital and then you do a respiratory test. You do a professional respiratory test, that's the device you need to count on, an expensive device within hospital, and then the nurse will guide you to do like 3 steps. You will inspire fully, and then you expire with the maximal efforts. After that, you inspire again with the maximal efforts, okay? So after this practice, what you will get is the flow volume curve. And such a flow volume curve means a lot to the doctor. They looking at the shape, the regular or irregular one, they will tell you the situation about the disease progression. And to make their life easier, then you will also calculate some lung function index like FVC, FEV1. Those are the particular index that the doctors have interest to know. But again, because this is a chronic disease, again, we cannot ask the patient go to the hospital so frequently. So that's why we'll naturally ask ourselves, can we just do this at home scenario? And we challenge ourselves by asking the question, can we enable spirometry function just on earphone? Because nowadays, a lot of earphone has microphone inside. So we build this, and then we run this entire our design model with Raspberry Pi, so in the edge device side. So why we can have such an idea, I think all I want to, throughout this talk, all I want to emphasize is, because we are working on the healthcare scenario, we need to understand the physical meaning. It's not saying, well, because now there's a AI developed so fast, so that's why we collect all the data we threw into the AI model, that's it. That's not the right way to do. You have to be able to understand what is the application scenario and what is the unique characteristic. And then you need to pay special attention to the useful and meaningful feature that is strongly related to the problem that you're interested in. For this spirometry, as you know, we are trying to get this flow volume curve. So that's why we're interested to have the flow rate idea. But how could we capture the flow rate? We find out a very interesting study. This is a physics people, they did a great job. They published in the Fluid Dynamics talking about airflow speed actually is highly related to the airflow sound. Sound is something we are very good at playing with it. So that's why this is give us a lot of opportunities. Saying we are putting the earphone, and the earphone has the microphone inside. With this captured sound, we could have the potential to make it correlated with the flow speed. Okay, so with this key observation, we design our architecture like this. So one half is how we play with the signal. So we'll do the audio feature extraction. And more importantly, because when I describe the way to use the spirometry test, we need to inhale, exhale fully, and then inhale again. So that's why we have this 3 phase. We need to also conduct a reasonable good phase segmentation. Only after we do those sophisticated signal processing, then the meaning, the data that we put to the model is much more meaningful. So with this, we designed a machine learning based flow volume curve estimation model to achieve the eventual target. And here, because the paper has been published, if you have interest, you can definitely refer to the paper for detail. But here I just want to highlight 2 design issues. The first issue is I just mentioned, to separate inhale and exhale phase is not that easy, especially the inhale part. Because when you are doing inhale, you can try it by yourself. You find out that when you are doing the inhale, the sound actually, because of the flow rate is low, the sound actually is very weak. As it's very weak, you may get confused whether this is really the inspired sound signal, or it's a noise signal, or even there could be nothing happen. So, but then the interesting part, again, we need to pay special attention on how to do the signal processing side. So we find out those 3 signals, they have quite distinct frequency distribution. So that's why we got a chance to design clustering algorithm to classify the 3 types of signals. And with this, we put it in the deep learning model that we built. And here, the model we build, we are doing the regression rather than the typical classification, because our eventual target is to get this flow volume curve. And eventually we recruit 60 subjects with the collaboration with hospital, and the subject agent from 20 to 70, and there are a reasonable portion of them are COPD patients. We also did a comparison with the ground truth spirometry, which is the version that has already passed the FDA certificate. And you can see that we can get a very good result in terms of the mean flow volume curve error and then also the fund index error. So I can show you a quick video. This is the PhD student drive this piece of work. And you can see this is the air hose, and then he used the mouthpiece just to make sure this is consistent with the equipment and the medical equipment that we are using to get the ground truth and then also doing the benchmark. And what he really need to do is just doing the inhale, exhale, inhale again. Exactly the same exercise as what you do to go to the hospital, but with the expensive equipment. Very good result. So this is kind of the type of research style my group have. We play with the device side, the sensing modality side. We also design the learning model so as to have a better understanding the signal, the captured modality information. So as I just mentioned, from the COPD's point of view, it's not only that I understand what's the situation. More importantly, what can you do for me? So that's why we have another piece of work. We're trying to do the training for the COPD patient. So again, the whole idea is that if you really got a COPD, you got diagnosed, the doctor will say that you should do some breath exercise at home. So therapists pretty much will guide you to do the diaphragmatic breathing. This is a very effective way if you can do it properly and you persistently do it at home. But do it properly and persistently doing it at home is not that easy. The reason is pretty much nobody tell me whether I'm doing correct or not. And if no feedback from the professional therapist or the feedback from the system, if there's no such a feedback, I kind of hard to really stick with such an exercise. So that's why by now, you pretty much will not be able to see much help offered to the home user in terms of how to do diaphragmatic breathing. But this is also even a troublesome, even for medical rehabilitation center. You ask the therapist, and then they do this hand by hand to touch your chest and then tell me so as they can really sense whether you do it correct or not. This is not that easy. So our idea is we're not just using the smart speaker and then a kind of a microphone array, so as we just using the ultrasonic to monitor the breath rate. Breath rate is too simple. More importantly, breath type. Because breath type is really about the shape of your body. So that's why there are a lot of challenges. First of all, we have to know this is really a breathing. And then also we need to differentiate this is a breathing cycle. And then within such a cycle, this is the inspiring phase and this is the expiring phase. So that's why we need to get a much fine-grained information comparing with just a breath rate related information. Moreover, when we are using the ultrasonic to transmit the information, and then we're using a microphone array to collect the data, we can see that the motion, the motion depth comparing with our whole body as the refraction surface is much larger than our breathing motion depth. So that's why we will facing the signal superposition problem. Another thing that we always need to bear in mind when we are do human related sensing is domain variation, because we could have different user there, and user are different in terms of their body shape, and more importantly, user are different in terms of their breathing capability. So with all this taken into consideration, here is our system design and then our real implementation. So we need to, again, play with the signal. We need to detect this is really a breathing signal. Through the cross-correlation and autocorrelation, we'll be able to detect properly about the cycle. And then we need to do the phase separation. We need to get in, clearly differentiate this inspiring and then outspiring phase. And after that, we need to design our deep learning model so as to do the proper breathing type classification. So here, we need to know that we collect all the data by ourselves. So that's why the data amount we can get actually is limited. So proper data augmentation tools need to be taken into consideration. And more importantly, we need to have new user join in, and we still need to be able to apply our scheme to them. So that's why a little bit like transfer tastes need to take into consideration in our learning scheme design. So here is the prototype of the system, and you can see that it's the smart speaker and the microphone array that work together. And you just need to put in on the table, and then you just sit next to a table, you do free breathing. So you see the student now have the chest belt there, but that breathing belt is only for doing the training data collection and then the ground truth collection. In the real setup, in the real testing phase, the user or the patient will not need to wear anything but doing the breath tap exercise. This, from the doctor's point of view, is very essential because our COPD patient, their breathing capability has been reduced significantly. If you ask them to wear something tightly to measure their condition, they may not even be able to breathe. So that's why the doctors are so welcome to see the contactless-based solution to help the patient. So again, we do the very comprehensive performance evaluation in terms of the breath rate, breath type, and then the classification, detection, accuracy, and we achieve reasonable good performance. Again, that you have a quick look about the quick video that to capture the real system. Again, now this is the students who drive this piece of work. He's sitting now doing the testing, and he's now starting the alphabetic breathing. Sorry, he's the alphabetic breathing. And then now the system will report the breathing rate, the in and then out ratio, as well as the breathing type. Again, as I just mentioned, this is a alphabetic one, so the system will detect this and then make the decision. And then later on, we ask the student to adjust to the chest breathing, so which is more normal. So we are get used to do the chest breath, but we kind of need to exercise ourselves a little bit so as we'll be able to do the alphabetic one. So you can see that the system actually will doing the detection about the, again, the breath type, the rate, and then other corresponding parameters. Okay, so that's pretty much setting the, again, the style of the research that our group are working on. So later on, I will show you, I will see that if time allowed, I will show you more examples. So I will show you like two examples relate to the contactless home monitoring. So this time we're playing with dry eye disease. So why I'm particularly interested in this, because for the limited students I'm supervising, I have three students confirmed for this dry eye disease already. This is again because the usage of laptop and those things too much. So anyhow, we work with the hospital and then we're working on this topic, early screening for dry eye disease. Now this time we're playing with wireless signal. So the dry eye actually is causing because the loss of the balance for the tear film, and then tear film, the stable tear film actually is very important for vision. So if you go to the hospital, you do the detection about the dry eye disease, they will give you a number of professional equipment to do the testing. So which is definitely very expensive, and then no one will want to do that in the early stage. They even don't aware of this. So that's why we want to see whether we can do early screening, because we have some like a very low cost and then portable equipment we can put at home scenario or lab scenario, etc. So the good thing is when we talk with the doctor, we find out dry eye disease actually has certain pattern and certain very good characteristic that if we do it correctly, we'll be able to capture. So dry eye disease, if you do the spontaneous blinking, we could find out incomplete blink, short blink interval, as well as prolonged eyelid close time. So with this taken into consideration, maybe we could get chance to do the entire spontaneous blinking process understanding. So that's why we come to this structure. So in this structure, you can see that we just leverage millimeter wave radar. So we have millimeter wave radar there, but we send out some special type of chip pattern. So with this chip pattern sending out, then we'll first detect the head position and we'll calculate the frame chip variance. And we remove all the noises behind the frame chip variance and be able to attract the biomarker that we just interested about in terms of the characteristic that I just briefly mentioned. So with this, we put in this to our designed deep learning model. So the whole idea is we want to have an unsupervised domain adaptation model so that when there are more users joining, especially new users joining, our system can still provide good results for them. So we implement all the solutions with the commercial millimeter wave radar as the basic sensing modality, and then we run our solution in the edge side, and we tested this by working with the hospital, recruit 54 participants, and then half of them, 27 of them are the confirmed dry eye disease patient. So you can see that our system can achieve around 97% accuracy in terms of dry eye disease detection in different scenarios, in hospital scenario, office scenario, home scenario, etc. So we are quite excited about this, and we are further working on this by trying to give more detailed understanding, not only just screening, detect whether yes or no, but we want to provide more detailed information with the help of large language model, with the help of some EHR data, electronic health record data we can get from the hospital. Hopefully, if we have more results, next time we can share that to give you update. So this is about the contactless part. And then we are also interested in terms of the home rehab. So for the home rehab part, I will use one of our work published last year to give you as an example. Again, this is a collaboration with another hospital. The doctors are working on the Parkinson's disease. We're particularly interested in this because, again, Parkinson's disease is the degenerative disease, and then we will see that there's no way to fully cure Parkinson's disease. But if we can do detection early, we could have chance to let the patient stay in the early stage longer. So people have some classification for the different progression level for the PD patients, starting from stage 1 to stage 5. And if you can do early detection, if you have good treatment, the patient may be able to stay in stay 1 to 3 stage longer enough so as to improve their life quality. But then the condition is we need to detect which stage he's in. And given in different stage, we should give the different treatment. Again, it's difficult to do those assessments if we rely on the patient go back to hospital frequently. So that's why we want to do the in-home detection. But for in-home detection, what can we leverage? There are a number of biomarkers that's been identified in our literature. So motor-based thing are the common ones researchers are working on, no matter it's gait or tremor. But first of all, those motor-related symptoms only happen when you are go to a little bit severe stage, starting from stage 3 and then above. So that's why not say very early, you have the motor symptom already. So this is one challenge. And moreover, you need to have an infrastructure to build so as you can capture the motor-related symptom. And recently, our community also working on the work that using the light time to capture the breath-related behavior. MIT Dina has a work related to that. After several years, demonstrate the nighttime breath-related information really be able to serve as a biomarker for the Parkinson's disease, which is nice. But again, nighttime breathing-related information collection, you need the infrastructure, particularly deploy millimeter wave, or it's definitely not convenient to have the chest bed to understand the breath-related condition. So that's why for this piece of work, we are particularly interested in voice biomarker. Because when we talk with the doctors, voice biomarker is pretty much suitable for all the different phases, different stages. You will find out voice situation, voice impairment level will got different. And more importantly, voice information will be able to collect with the out-of-shape device. We have smart speakers here and there. So considering this, there's some literature working on voice task-specific PD assessment in the way that because when we have different PD stage, the impairment for the voice, for the pronunciation, actually is focused on certain part of your conversation. So that's why if we particularly come out some content which has a lot of feature related to the voice impairment, you could have better result. So that's why definitely high accuracy will be given out. But then the bad thing is, if you ask me to do this once, that's okay. But if you ask me to do multiple times, I have the repeated content. Because of the content familiarity, then the long-term accuracy got decreased. Moreover, patients normally hate, especially elderly patients suffer from the Parkinson's disease. They hate to be examined in a very explicit manner. So that's why our question is, can we just leverage the free speech? Anyhow, everyone need to talk. Can we just leverage this free speech to do the Parkinson's disease assessment? If we can do that, that would be wonderful. That would be purely passive manner. But as we know, this is a free speech, so that's why the performance has a question mark. And then also because I'm doing my free daily talk, that potentially has a privacy concern. So in this piece of work, we're trying to design an effective, privacy preserving free speech based solution. So our observation actually is pretty clean in the way that why free speech solution is tough is because of the linguistic content variation. And for this piece of work we are doing in the Mandarin, so the language we are testing is in Mandarin because we get a lot of patients recruited in mainland China. But anyhow, the linguistic content, you can see that if this is a controlled content, if the content is controlled one. And you can see that even though there could be performance difference, but you with different feature extraction scheme, you still can see that they can differentiate them. But if this is a free speech, none of the existing solution work well. So that's why in our work, we leverage the pre-trained automatic speech recognition model to help us to do the feature extraction. The rationale for this is pretty much the Hubert scheme, which is a self-supervised learning based automatic speech recognition model, has a backbone, has a transformer as a backbone. And transformer as a backbone is suitable for the sequential data. Audio is definitely a good sequential data. So that's why it can help to enable a better feature extraction. Moreover, the self-supervised learning can help to further enrich the features fidelity in terms of the linguistic, in terms of the speaker-related characteristic. And moreover, it has a massive amount of pre-trained data, so which can also help us to generalize it to the real-world setup. So with this, we actually design our scheme. But even with this as a basic idea, there are still challenges in terms of, even though we know the voice impaired level, considering different PD stages different, but that difference is quite subtle. So how can we really be able to differentiate? And moreover, we did a lot of collaboration with the hospital doctors, and the patient go to see the doctor, normally at stage 2 and then above already. So that's why we're very tough to get a stage 1 patient. So that's why we'll see the unevenly distributed in terms of our test data set. Moreover, as I just mentioned, the privacy leakage is also the challenge. So that's why with this, we designed the PD assessment model, and then also the privacy preserving training mechanism. So in terms of the assessment model, we have a lightweight feature extractor, and also we have a particularly designed an attention mechanism scheme so as to focus on the particular features that we are particularly interested in relate to the PD and then relate to the voice impairment. And in terms of the privacy preserving one, we adopt a split learning in our scheme, and moreover, considering the potential FSHA attack that people already raise out, we incorporate domain adversary training in the pseudo acoustic unit so as we can further eliminate the content information from the embedding so as we can preserve the privacy. So again, I will not go into too much details. You can always check about our paper. So the interesting to report that we recruit 100 users in this particular piece of work. And you see the room here actually is next to the clinic. In the hospital, we have 2 rooms. One is the outpatients checking room that the doctor is talking with the patient, and then later the patient will be referred by the doctor. Yeah, the compliance to the doctor actually is a very essential part when we're doing the healthcare related application. So the doctor will refer the user come to this room, and then we'll do some like a very random talk with the patient. They will just be here for like 1 to 2 minutes, free talk with us. Eventually we get a very good result, different stage, the overall performance. Yeah, I will just very quickly doing a highlight about some of work that we do relate to the food part. I think I was just using this one slide talking about food related work that we're doing. So we pretty much playing with the light sensing modality. Again, because when we are playing with different spectrum, So when you are using different spectrum and different spectrum putting different material or different food on top of the light transmitter, you will doing the reflection. Such a reflection actually in different frequency because of the nutrition different, the reflection percentage is different. The reflection ratio is different. So with this, we'll be able to infer what are the food in terms of type, in terms of nutrition. And then we start working on this back to like 5 to 6 years ago. And then we continue doing this with more advanced learning technique and with our like hardware equipment related design associated with it. So we'll be able to do the food carrier estimation. We'll also even be able to understand baby food nutrition level with the spectral reconstruction. Okay, so I think I will just skip this piece of work. And then I want to end by the last slides. I think this area, there are a lot of interesting opportunities. So that's why we're, again, pretty much working on this align multiple direction. First of all, talking with doctor, talking with the user, and thinking about what user needs is the most important thing to drive all the research work. So our idea is with more and more technology involved, we'll provide more personalized digital therapy. And those digital therapy can include what you eat, nutrition, how you exercise, what kind of rehabilitation intervention we can provide to you, etc., etc. So there will be more health prescription that we can provide with the technology development. In terms of the development, in terms of technology side, we again emphasize on two directions. First direction, there are more sensing modality. So that's why multi-model based study is worth trying. And moreover, there are different type of sensing modality coming out. For example, we are playing with RF. And then nowadays, there are a lot of interesting ideas in terms of the metaverse, meta surface or reconfigurable intelligent surface that can help us to further enhance the wireless signal condition or even acoustic signal condition quality. So all this potential tech enhancement align the sensing modality can help us get richer and high quality signal. And then there are a lot of development related to AI model in terms of the large model, and more importantly, in terms of how to adopt the proper large model to the edge side or even to the tiny side with the resource constraint. How can we adopt the proper model so as playing with our multi-sensing modality, we can get better result. And moreover, there are always privacy-related issue. There are always issue related whether your learning scheme is robust enough, people can generate adversary attack out of your learning protocol, etc. So there are a lot of interesting ongoing discussion. And with this, I want to stop here. I'm willing to take any question.
Thank you very much. If you have questions, audience, please put them in the chat and we'll read them. I don't see any questions for them. Oh, there's a question already. I will read that first. So Tong asks, beyond using the microphone array to capture the movement, do you think it is possible to use in and out earphones using breathing sounds to detect diaphragmatic breathing?
Interesting, but it could be difficult. It could be difficult in the way that when we are doing this diaphragmatic breathing, the difference is put it this way. So when you are doing the chest breathing or versus diaphragmatic breathing, the shape of your body will will be changed. So you will see the chest and versus the stomach, and the shape actually so in terms of the breathing type, we care more about the shape. And the shape of the body, actually, if you only have the in-ear microphone, you're only basing on sound-related information. I would imagine that would be very difficult. That would be very difficult.
Thank you. I have another question about your, at some point, I can't remember if it was the first work, I think it must have been the first work. You talk about augmentation, the fact that you augment with other sounds. I wonder if you want to talk more about the kind of augmentations you do there.
Yeah, I think in terms of the argumentation, it's more like about because the again, we have small sample. So it's all about, again, because we collect all the data by ourselves. So that's actually the difficulty and challenges we're facing when we're doing smart healthcare related application. So that's why with the small sample, we're trying to do the kind of generated certain like a similar kind of pattern data. So as even with the small sample, we'll be able to train the model, not overfitting and then etc. So the argumentation side is really about that.
Yeah, so you just modify the signal you have, you just add noise and do the usual.
Yeah. We add certain randomness and then we emphasize the part. Yeah, that's true. That's true.
I was wondering if you use that. The reason I asked the question is because I wonder if you use other data sets or
so for this several piece of work we didn't, but actually now we are working on the align this breathing. We're again working with the doctors about to check about the volume and then the pattern in all together. And then the volume, actually we're trying to not use the maximal volume because I'm not using the maximal efforts, but just like a little bit effort, not to the maximal level. So for that, we actually are checking with the video, which is related to people are doing the breathing related exercise. Yeah, we are using that.
So you do a multi-sensing kind of multi-channel.
That's true. We are multi-modality fusions related body. Yeah.
Understood. There is another question by Jing. Thank you for the talk. I have a question about the DED. How would the technique distinguish between natural eye blinking and people who generate some eye blink made on purpose, like fake ones, which might mimic the DED pattern like fake DED? Would it be great to listen to your opinion?
Thank you for the question. Yeah, actually, the reason we are saying this is a spontaneous one is like it's not only capture the blinking itself, it's during the blinking you have certain pattern in terms of I just mentioned the prolonged eyelid closing time and then shorten the interval and then etc. So it's first of all we need to capture the blinking part, and then second we need to also capture the after we capture the blinking, we need to extract the biomarker out of the blinking. So even you do some like non-natural, we are not saying fake, you are now doing some non-natural blinking, will be able to capture that.
Okay, thank you very much. I think we're coming up to the hour and I know it's quite late for you. So I thank you again. We'll probably be in touch. There's quite a bit of overlap between what you have kindly presented and our research. So it was good to see. And we'll put the recording online and thank you very much. See you soon.
Okay, thank you. Yeah, I'm looking forward to see some potential collaboration too.
Definitely. Yeah, I'm also keen. I think Tom will close the Zoom. Yeah.
Okay, thank you. Bye.